Welcome. Thank you all for coming tonight. It's a pleasure to introduce tonight's speaker to you. Rachael Schmoker is a student here at the University of Montana who's a community health major, and she's also a minor in international development studies and global public health, with a specialization, a Peace Corps specialization in health, and one in youth and community development. She spent 3 months in the summer of 2014 in Khayelitsha, South Africa, a township just outside of Cape Town. She was working there with HIV/AIDS organizations, and she nowadays is working with me and a couple of her colleagues on a global leadership initiative, capstone project that involves work with low-income populations both here in Missoula and in South Africa. Rachael will be graduating this spring, and she hopes to attend a Master's International Peace Corps graduate program for global public health starting in the fall of 2016. And I would add that she is the recipient of the first award to a global public health minor offered by the External Advisory Committee of the Global Public Health Program, based on a small amount of funds that they were able to raise. Rachael's topic for tonight is healthcare challenges in Khayelitsha, South Africa, addressing HIV prevalence through the social construction of disease. So please join me in welcoming Rachael Schmoker.
So hi, and again, my name is Rachael Schmoker. Hopefully this microphone is not going to trip me out. It's a little bit loud. So I know that Peter read off of my academic focuses, and I know it's a whole ramble, but essentially it surmounts into international public health, and that's really my focus. I've been studying HIV/AIDS and sexual infections in sub-Saharan Africa for the last 4 years or so through my undergraduate work, and I found it very, very interesting. And I'll explain why it's so fascinating and how this disease is expressed very, very differently in sub-Saharan Africa versus the rest of the world. So today we're talking about HIV/AIDS in sub-Saharan Africa, and specifically in South Africa. And I just want to point out, just to give a little background on the rest of the world. So this is kind of what the 2013 rates for HIV look like in the world. And we see that the darkest blue areas are in sub-Saharan Africa, and in fact 70% of HIV prevalence rates lies in this area, versus the 0.8 global prevalence rate. And within South Africa alone, it's 17%. And so why is the rate so high in sub-Saharan Africa? Well, we will find out today. And so what I really want to talk about is how culture defines the spread of disease and how it's specific in sub-Saharan Africa versus the rest of the world. So to give a little background, understanding that HIV stands for a human immunodeficiency virus, whereas AIDS stands for the acquired immune deficiency syndrome. And really, really briefly, how HIV is transferred is you have these cells that invade the CD4 cells, which lie in your immune system. They replicate within the CD4 cells, and then once the HIV has been replicated, it then fights that CD4 cells so that you have less CD4 cells and more HIV cells, and that kind of accounts to your viral load. And your viral load corresponds to the stage of your infection. There are currently 4 stages that they have. They're always changing how they're talking about AIDS and how they're talking about HIV, but essentially the amount of viral load and virus in your body refers to the stage of HIV that you have, as well as it'll determine your antiretroviral treatment, and I'll be calling that ARTs for the remainder of the talk. And HIV is transferred through 4 mediums: breast milk, blood, semen, and then vaginal and rectal fluids. And it's really important that we understand these 4 mediums versus a lot of other myths about coughing or kissing or saliva or any of those kind of mediums in which it cannot be transferred. The other factor that's important in noticing about HIV transmission is this asymptomatic waiting period. When you get, say this is your HIV infection that you'll be exposed to, you have to wait about 3 months until you can really accurately test for it. And that's sort of the fact that when you're testing for HIV, you test for the antibody response within your blood. And we see with this blue line that it's really not apparent until about 3 months, despite the fact there's a high viral load. And during this asymptomatic period, you won't really have any symptoms. The only symptom that you will first acquire is a flu-like symptoms. You'll think it's like a flu, and then it can be essentially dormant for many years until the viral load eventually becomes high enough that your immune system is really responding to that. So we're going to get a little bit more into the context and why HIV is expressed so differently in sub-Saharan Africa, particularly South Africa. And one of the reasons is due to these gender roles and the idea that if a culture is valuing a certain health behavior, you'll most likely do it. So in Western cultures, going to the dentist, we value that in our culture. Whereas in South Africa, they value very, very different things. So before we kind of get into these traditional values and these ideas behind genders, I just want to talk a little bit about same-sex interactions. So South Africa has legalized gay marriage, and there are certain implications that specify that within the country. However, the majority of my talk is really talking about heterosexual partnerings due to the fact that women and children have the highest prevalence rates of HIV. And even though that gay marriage is legal, there is a lot of correctional rapes that happen, and so it's really not accepted within the community. So most of these numbers are really referring to the heterosexual relationships. So these three ideas are really key in understanding how social ideas are developed. So polygamy means that a male have multiple wives. Patriarchality means that a woman will go, when they are married to a man, they will go into the male's home and become a part of that family. And that's how kind of the families are built. And then patrilineality with bride wealth, essentially that woman can be bought and have this value placed on them. And these ideas behind what a woman is in a relationship really dictate these social constructions of how people operate within their environment. So we see all of these ideas behind stigma and denial, and that's related to the HIV prevalence rates and whether or not you feel accepted enough to go get tested and to come out with this disease. We also have a lot of gender-based violence, and that's due to the gender roles that we see within South Africa and the cultural context. We see a lot of poverty in these townships, and I'll be talking a little bit more about what the townships look like and why it's so impoverished, as well as lack of opportunity in these townships. There's a huge amount of age disparity, and I'll bring up some statistics in the end as well. And then essentially just overarchingly power dynamics between the males and the females and what is warranted in these sexual practices. So specifically, all of these constructions lead into what sexual practices are used in this community. So a couple factors that increase the incidence and the prevalence rates of HIV. Mistrust of condom use is a huge, huge factor. Essentially, if a woman asks a male to put on a condom, whether or not they're in a relationship or married or whatever their relationship is, the male will believe that you're cheating on them. And so condom use is really, really not available. Sometimes people can't voice that and can't ask for that. And condoms is the best way to protect against HIV and that transmission. Intergenerational partnering is a huge, huge deal. There's a lot of young women who are having sex before 15 and before 13 years old, and they're having sex with much older men. And we know that the longer you're sexually active, the higher chances that you have an HIV or STIs. There's also transactional sex, so a lot of prostitution that goes on in these communities in order for females to have any sort of say or any sort of stakeholding in the economic activities of their family. There's a lot of sexual violence due to the gender-based dynamics that we see, as well as dry sex and other high-risk practices. And just for a little bit of background for people who are less of a health knowledge, when you have dry sex, it essentially refers to the cultural practice to use drying out potions or herbs to dry out the vagina. And wet women are considered unchaste in the community, and so this is for male pleasure and just for the sexual practice within the community. And when you have this dry sex, you have a lot more chances for micro tears, and that really transmits the rate of HIV through blood and through the semen. And so these are really, really high-risk practices that they're using. And if you're pairing dry sex and these micro tears with a mistrust of condom use, then you really have a high rate of HIV transmission. There's also a lot of stigma associated with this disease. AIDS is correlated with being dirty, having low moral character and high sexual promiscuity, despite the fact that a lot of these instances, people are unable to voice either wearing a condom or even having the sexual act at all. We see a lot of young girls being raped in these communities. A girl has a higher chance of being or sexually assaulted than they do have of graduating high school, and that's in these townships. And it's really, really hard to walk around in these townships and see these young girls and know this statistic, and realizing that a lot of people have had these experiences. And again, HIV status is linked to discrimination, victimization, isolation, and it factors into two things. One, you don't even want to get tested. You don't want to get associated with this disease in any way. And two, if you are associated with the disease, your adherence rates and your ability to properly take the ART treatment really, really decreases, because you're unable to speak to your family members and your support systems to say, hey, I have this disease, I'll be taking this pill every day, help me with this. And so if you don't have that support system or feel like you are accepted in the community with this status, then it can be really detrimental and lead to high mortality rates. So this picture to your right is a campaign that Treatment Action Campaign did, and that's the organization I'll be talking about, in which I worked for 3 months. And they've really, really tried to decrease the stigma in these communities and raise solidarity through these t-shirts, HIV positive. So we see that knowing your status is also a really empowering way to decrease the prevalence rates of HIV. And we see higher rates correspond with females. However, there's still these very high statistics that 62% of HIV positive in males and 45% of HIV positive females still are unaware of their status. And so this links into the spread. So within Western cultures, we have this general idea that monogamy is kind of the overarching basis. We have, on a general basis, one man with one woman at one time. And of course, there are exceptions with this. But in South African communities and in a lot of sub-Saharan communities, the culture is really polygamous. And so we have this web of sexual partnering. And whether or not you're married, or whether or not you're just in a casual relationship, this happens very, very frequently. And so if you look at these dots, and pretend that the large dot is the individual and they're having sex with 3 other people, they also may be having, 6 other people, they also may be having other sex as well. And so the more people you're partnered with, the higher chances of transmitting any sort of sexual infection. And I've talked a little bit about the social constructs and how that really plays into the HIV prevalence and incidence rates. And now I'll be talking a little bit about the behavioral determinants and why specific behaviors lead to higher rates of HIV in these communities. So again, these are some statistics about multiple partnerings. And so the darkest red is the 2012 data, and this is from the South African HIV prevalence report. And so it's very new data, and we see the highest rates of multiple partnering within the 15 and 24 generation of males, and that is with 37.5% of males having more than one partner. And then we see the very, very low within females. And adding on to this, we see that 33% of females have a partner 5 years her senior. And that's compared to the 4% of males. So we understand that the longer a male or a female is sexually active, the more chances they have of transferring any sort of diseases. And so when we see 33% of females who are very, very young women having sex with much older men, her rates and her risk of HIV increase dramatically. We also see that condom use is not really used. So this is a confusing chart, because it's talking about condom use by last sex. So that's important to note. So in the 2012 reports, males who between 15 and 24 report 67% of the time that they wore a condom the last time they had sex, versus 49% of females. And that's kind of a big difference. And that's because depending on what demographic you're looking at, condom use consistency ranges from 25 to 50%. So regardless of the fact if you're using a condom the last time you had sex, maybe the 3 times before that you didn't. And then that also increases your rates. And so if we pair condom use and inconsistency of using condoms, these dry sex and other high sex practices that really increase the interaction between blood and semen in this HIV transmission rates, as well as having multiple partners, your risk of having HIV and spreading this is really, really dramatically increased. And particularly for women and children, when they don't have a lot of voice or say in the community to ask for better safe sex practices, it won't really happen. And again, noting that this is socially constructed. So if a culture values a certain action or activity within the health field, the citizens and society will most likely do that. And in South Africa, safe sex is not really valued within the community, and thus it's really, really hard to actively voice that. There's also this high denial of risk, and this really stems from political involvement and this denial that HIV actually exists. And so we see that 72% of people believe they're not at risk at all. And when we look at all these social determinants, that kind of is a really high statistic. And some of the things that they account to this are faithfulness, abstinence, and the use of condoms. Whereas if we just saw in all these statistics that faithfulness is not really there, there's a lot of people having multiple partners. Abstinence may not be a viable option because you may not be able to voice that. You know, again, more female girls are more likely to get raped than they are to graduate high school. And then the use of condoms, the consistency is just not there. And paired with that, only 30% or less than that really understand how HIV is spread and transmitted. And when we see that, and we also know that a lot of people don't understand that HIV is not a death sentence any longer. We have ART treatment that is really, really effective. However, it's only effective if you have a good support system and you can have high adherence rates. And when people don't really understand how HIV is spread, they're less likely to get tested because of this large stigma. Because if they think that it's a death sentence, and they know that if they are confirmed as HIV positive, they will have not only a death sentence on their back, but they will also have discrimination within their community. So it really, really decreases the benefits of even getting tested. So this is a little bit talking about how South Africa is very, very different, remembering back to that 70% HIV prevalence rate in sub-Saharan Africa and 17% within South Africa. We see that in the rest of the world, men who have sex with men and injection drug users have the highest rates. And that's because with men who have sex with men, anal penetration has a lot more chances for micro tears, and so that transmits HIV quicker. And then we also see with injection drug users, unless you're really cleaning your needles very thoroughly and you're not sharing, your rates of transmitting the disease through blood is really high. And within mothers and children, that's why South Africa is very different, because the highest rates are within mothers and children. And there's a lot going on, but I just kind of want to note a couple things. So we have 25% of the proportion of people living with HIV on ART treatment, and that's among males. And we have a 10% increase among females. And we also see that when there's a huge, huge disparity between the amount of males on on ART treatment versus those who are HIV positive. And again, this does refer back to the viral load, and some of those individuals may not be quantified into having ART treatment, but generally it's due to the fact that there's less adherence among males because there's all this social stigma, and they also don't see a benefit of taking these drugs that have some pretty nasty side effects. And again, down at the bottom here, we see 6 million people in South Africa alone are HIV positive, and only 2 million of those have ART treatment. And this is talking about HIV prevalence and just showing the data about how females have much higher percentages than males. And when we see these high prevalence rates, it's also important to note the high incidence rates. That the incidence rates essentially means the new infections within the population versus the overall population having this disease, which is the prevalence. We see the incidence rates for female use are 4 times higher than male use, and that's partially due to the gender-based violence, dry sex practices, and having these multiple partners who are much 5 years her senior. So that was a lot of background talking about the overall idea of HIV/AIDS in South Africa and why it has become socially constructed, and how South Africa and sub-Saharan Africa is much different from the rest of the world due to these socially constructed values placed on the society. And now I'll be talking a little bit more about my work in Treatment Action Campaign. So like Peter said, I spent this last summer in 3 months working in Khayelitsha, which is a township just about 15 kilometers outside to the east of Cape Town. And they are known as one of the most effective AIDS organizations in the entire world. They were founded in 1998, and they were founded because they noticed these high prevalence rates, and they really thought it was under the South African government's duty to provide ART treatment to their citizens. Eventually, they did get that passed. They also were able to encourage research to be done so that they decrease the treatment from 5 pills a day to 1 pill a day, because we know that if you only need to take 1 pill a day, you're more likely to have better adherence for this treatment versus taking 5 pills, particularly when you're in a community that's very stigmatized. And Treatment Action Campaign now has evolved into a couple other different campaigns, which I'll be talking about. But one of the reasons that they're so effective is these condom distributions and simply having access within the community. And I know this is kind of a weird picture, but this is because it's taken out of a moving vehicle. And they do these condom distributions for an entire week every single month. So there's 12 weeks out of the year in which they do the distributions. And I went on one of them for 1 day. And in that 1 day, we distributed 80,000 condoms within the townships. That is a lot of condoms. And so having all this access, and if you have this condom, you're more likely to use it, rather than this idea of like, oh, wait, I have to go somewhere else to get a condom, and then I don't really want to do it because it's ruining the whole moment. So we're really believing that if people have them, they will use it. And I would essentially, we'd pile in this huge car, and we'd have these boxes and boxes and boxes of condoms in the back, and I would literally just yell at the window, condoms, condoms, because I don't know how to speak Xhosa, which is the population that I was working with. And people would literally walk down the street because they know that Treatment Action Campaign supplies this service, and so they know, that I'm not just some random person, this random white individual in this very, very black South African community giving out people condoms. So this was one of the coolest experiences that I went on. And a little bit more about the community. So Khayelitsha exists in this area that's outlined, and it's about 15 square miles, and it lies about 15 kilometers to the east of Cape Town, which is over here. And we see amazing wealth within Cape Town. I am standing on Lion's Head, and I'm looking out over this vast amount of lights, and we can just see how wealthy Cape Town is, and how much infrastructure and economic activity they have, and how good of quality of life Cape Townians have. And then just 15 kilometers away, we see the townships. And essentially, well, I'll get back to what the townships, how they were developed, but it's very, very impoverished. There's lack of infrastructure. In Khayelitsha, the township, there's about 1 million people in 15 square miles. That is a huge density population. And the unemployment rate is 60% because many people live in informal settings. They have they have lack of resources and infrastructure, so their education systems are pretty poor. Essentially, the history around townships and all this area, essentially to the east, is all townships, give or take a few communities. And during the apartheid movement, the white South Africans, the Dutch, moved all of the black South Africans out of Cape Town, and they pushed them into these small settlements called townships. And the city planners who made these townships really planned for a lot less people. They planned for about half or even a third of the amount of people that actually live there right now. So again, Khayelitsha has grown. I looked at data from about 5 years ago, and it was half the size. So it's grown, doubled in 5 years or so. And so that is why we see a lot of these informal settlements. There's not a lot of money going into these townships, and just the quality of life is really, really poor. We also see in Cape Town, it was the host of the World Cup in 2010. It was the World Design Center just last year in 2014. And it essentially is considered separate from Africa because of the wealth that we see there. Versus the townships, and Khayelitsha is just one such example, but we have high unemployment, we have high rates of violence, we have lack of resources, and we have a huge high density. And the high density really relates to a lot of the infections and how that's being spread. So again, like I said, Treatment Action Campaign is shifting away from ART treatment because that is really advocated for already, and into these three separate areas that I'll be talking about. So the first one is the distribution and prevention and support systems. So we know that when people have a better support system for the medications, they're more likely to adhere to their medication treatment. And in these townships, there's very, very limited clinics and support. And so when an individual needs to go for their monthly checkup for their HIV treatment, they have to wait in line in queues for the entire day, and they have to take work off. And so a lot of people don't do that because they can't take work off because they're impoverished. So we have these clubs that exist outside of the clinic system. So there's 30 people in a club or so, and right now there's about 40 groups within Khayelitsha, which is a 12,000 patient reduction on the healthcare system, which is really, really beneficial to those who really need to go to see the doctors and the nurses in these clinics. So essentially these clubs meet half the time. They meet once every 2 months, so it's 6 times a year, and they get their ART treatment, they get their checkups to make sure they're maintaining their weight, their viral load, and maintaining their treatment. In this way, they also have a lot of social support, so that if an individual misses one of these meetings, you know where they live, because they live in these township communities. So I can walk over after the meeting and say, hey, Susie, why didn't you come to the meeting? You need to get your ART treatment. And we know that these social pressures really greatly increase your adherence rates. We also see a great amount of TB that's associated with HIV. And that is because your immune system is really decreased due to your viral load counts and the lack of CD4 cells in your body. So Treatment Action Campaign is really trying to work to increase the clinical support and essentially the administrative aspects of it. So making sure that when you go to a clinic, you're not waiting for 30 minutes, you're not seeing individuals coughing all around you, you're seeing a lot of open air ventilation. Because due to the high density, if I have TB and there's not a lot of ventilation and air circulation within the room, a lot of other people will get TB as well. A couple different statistics for you. A lot of people died in South Africa due to TB in 2012, I believe is the data from. And then even more people have increased their TB infections. And multi-drug-resistant TB doubled from 7,000 to 14,000 new cases. So there's a lot of TB cases that we see in Khayelitsha and South Africa alone. So these data is from South Africa, not just in the township I was in. I saw this quote and I thought it was really, really pertinent to how TB and other infections are handled within South Africa. How does a preventable, curable disease become the leading cause of all natural deaths in South Africa and the leading cause of all AIDS-related mortalities on our continent? We mismanage it for decades in health structures with poor infection control, weak diagnostic capacity, insufficient education on TB, inadequate resources, and minimal political commitment. We don't worry about this too much until multiple drug-resistant TB explodes in our faces. And how multiple drug-resistant TB essentially is created, it's created by people who have TB, who don't adhere to their medications, and then they only take portions of their medications, so then the TB will then adapt to these situations and adapt to the drugs. And now we have created multi-drug-resistant TB in which there's very, very little pills and medications to take. Right now, the medication for drug-resistant TB is really, really poor, and people do not take it because it can cause deafness, it causes nausea, it causes you to not eat at all, and so it's really, really, it's more negative than having TB in itself. One of the other notions that TB has been doing, yesterday was World TB Day, so that's awesome. So there's a lot of protests and demonstrations to create solidarity and raise awareness about the fact that TB is killing off so many South Africans. And Treatment Action Campaign put on this protest about 5,000 people from multiple organizations to come together to encourage the South African Council to get tested for TB, to increase solidarity and to raise awareness for this disease, and that understanding that a lot of people are dying from this disease. Social justice campaigns is really, really the hot ticket right now for Treatment Action Campaign. Remembering back to these social constructions of gender, there's a lot of gender-based violence that we see in these communities, and there's little action and little voice that people can have for them. So Treatment Action Campaign is really trying to be the voice for these individuals. And this is the Khayelitsha Magistrate Courthouse, and they're doing a demonstration regarding a trial that's going on in order to have this support for them, despite the fact that there's a lot of corruption within the law enforcement agencies, and most cases don't really go anywhere. But it's this idea that there's an organization that's backing your case. And so a little bit into my experience. So I was able to attend a lot of interesting experiences with Treatment Action Campaign. They do a lot surrounding their organization, and I was only in one such branch. I was in the branch for Khayelitsha. And one of the experiences that I had was going to this leadership conference. So Treatment Action Campaign really tries to utilize the voices of the community and have it very, very community driven rather than having outside people come in and tell you what your community needs. And so I was able to go for an entire day in Khayelitsha, which was another township. And again, these are all Norse-speaking people, so I was the only white person there who spoke English. And so the whole time I was just kind of sitting around, listening to people speaking in cliques around me, but I got the general gist of it. And they bring in Salam Investments, which is an organization based out of the townships, and they really try to understand prejudices around leadership and biases that we have, and understand that a leader does not have to be someone who is shouting from the rooftops, making a lot of noise, but it has to be someone who is very, very passionate and who can work within the community and raise the community's voices. One such story that I just kind of wanted to share with you guys that really shows how far South Africa has come and how many leaders really are present within these communities. One of the activities was for individuals to come up and share their stories. And this girl who's about 13 years old, she goes up and she talks about how her mother was a drug addict, her father sexually abused her and her sisters, and she was a drug addict as well. And she was about 2 months sober at this point, which was amazing. And she's up there, she's at this leadership conference for some Treatment Action Campaign trying to reduce stigma for HIV/AIDS as well as gender-based violence. And she was this 13-year-old girl who was really being an amazing leader in her community. So I thought that was a really, really amazing thing that Treatment Action Campaign does to pull all these individuals and to empower them to make a difference in their community. I also spent a couple days at the Khayelitsha Magistrate's Courthouse, and it was for this gender-based violence campaign. There was a pastor who had been accused of raping 2 women, and we were there. He was on his trial to get out on bail, and sadly enough, he also did get on bail, despite all this overwhelming evidence. But when we were there, it was really interesting to note the types of demonstrations and acts that they do when they're out. So this is outside the courthouse, and you can kind of see that there's clapping and there's singing going on. And when you're there, people are singing and dancing out in the oval, in the little area that's right in front of the courthouse. So they're not necessarily going in and having a very civil and serious conversation. They're out in the oval and they're using their voices to spread their opinions. And it was really cool because my fellow intern and I were singing and dancing in Norsa, and we had no idea what we were saying. We knew we were having solidarity for these individuals. This next picture kind of sums up my entire experience. There's a lot of ups and downs, a lot of roller coasters when I was in Khayelitsha and working in this tiny office and not really knowing what anybody was saying around me. And one day, after a really tough day, and there was a lot of rain that day, there was this amazing rainbow over these shacks and over these this really difficult situation that these people are in. And I kind of felt that Treatment Action Campaign, I know it's really cheesy, but I kind of feel like that they were like the rainbow over for these people because they have done so much work to decrease the stigma and to decrease the TB prevalence rates and to have all these campaigns that really bring up the community's voice when they're in a situation in which they don't trust the politics, they don't trust the law enforcement agencies, and they essentially have little opportunity to get out of the environment in which they're in. And Treatment Action Campaign is there trying to increase that voice for people. I know we've talked a lot about how there's so much negativity in these communities, and there's really little hope for them to get out of this. But I do want to point out some really, really amazing statistics. There are now 2.5 million people on ART treatment, and it is essentially making it the country with the highest numbers in the entire world, and that is really, really powerful. And granted, they have a lot of HIV-positive individuals to pull from, but just this fact is really empowering. And within 5 years, we've increased the number of clinics from 500 clinics to 3,500 clinics that offer HIV drugs. So essentially, going back to this condom usage, access to condoms and access to ART treatment will greatly increase their usage. We also see that mother-to-child transmission rates have dramatically dropped. They've dropped 90%. Incidence rates have dropped 33%, and the life expectancy has increased 10 years. And this is all from data that's from 5 years ago. So within 5 years, all this data has come out, and we've seen these dramatic increases. So I know South Africa is really far away, but there are some things that we can do within our community, within Missoula, to increase the world's awareness, to decrease stigma, and to get tested. Getting tested really increases the world awareness around this and decreases the stigma. When we decrease the stigma, we're more likely to help people who are in need of these drugs. So here are some organizations that within our local community do HIV testings. And to remember that 3 months after risky sexual activity is the best time to get tested. But essentially, every year or whenever you need to get tested, to understand and to know your status and why that's really important. So that kind of wraps up my speech. I'm really glad that you guys were all here to listen, and I will take any questions you guys have to talk about anything about HIV in South Africa or in Khayelitsha. Yeah.
Is the data and the percentages from all of South Africa, for just the townships, for just the black colors?
Good question. Yeah, so all this data is from South Africa in general. And we see, the only statistics I have for Khayelitsha is that it's 1 million people in it. And the townships have very, very little resources. There's not much data that is going into testing how many HIV instances are in these townships, because you really don't have a lot of resources to do that testing. There's a lot of informal settlements that exist in these areas, and there's really no way to test how many people are actually who are actually HIV positive in this area. And they are for the entire population, not just Black South Africans.
So it's everybody, including white people?
Correct. Correct.
Tell us a little bit about treatment action campaign. Where do they get their funding from? Who started it? That kind of thing.
Yeah, so it was started by an individual, and I forget which township he was from, but he's from Cape Town and the township surrounding Cape Town, and he noticed that there was a lot of HIV prevalence rates, and he really wanted to do something within the community. And they are they are not federally funded, because they know that if you're federally funded, you have a lot of restrictions based on you. So they are really funded by donations and other organizations around the world that submit money towards their campaigns.
In much of Africa, they're now promoting circumcision as a preventive tool. Are they doing that there?
They're doing a lot of male circumcision, exactly, yes. When I was there, I was working in more of an activism campaign, but there's a lot of individuals who were working in the clinics next to me, and they were seeing a lot of male circumcision, because that decreases your rates because you have less little pockets. Any more questions? Yeah.
Do you think treatment action campaign is doing enough for gender inequalities to just really attack the core of the whole problem?
Yeah, so the question was about whether or not treatment action campaign is doing enough for gender-based violence. And in some instances, I want to say yes, because they have done a lot of work, but also not really. Because the individuals that I am working with, a lot of them are really empowered, and a lot of them really do have more modern perspectives on gender and gender equality. But still, a lot of people are working there, and they don't have those ideas. When I was working with one of the organizations, I was talking with this man, and the comments that he was saying definitely did not align with the overall organization, and they align with a lot of risky sexual activities, and it was just really interesting that he was working for this organization. So I think it's really, really hard, because you have to get at the root of the culture. And when the culture doesn't value safe-sex practices or gender equality, then it's really not going to happen within the community. So raising awareness and encouraging women to think outside of the situation that they're in. I mean, they're put in this box. They grow up in these townships. They see the relationships that their parents and that the people around them have, and it's hard for them to imagine a life any different. One of the most empowering things that I learned, that I was able to experience when I was there, was I was at a youth adherence clinic, and I was speaking with this woman, and I asked her, you know, if you want to share with me, why did you become part of this this field? Because HIV/AIDS is so stigmatized in the community. Why would you want to, you know, voluntarily put yourself in that situation? And she goes, oh no, I don't know. I don't really know. And we just kind of sit there in silence for a few minutes, and then she goes, you know, I do remember. I do know why I am in this profession. Her brother had died 10 years prior and died of HIV. And at the time, she knew nothing about HIV. She knew not how it was spread or how it affects your body or how you get treated. And she told me, you know, that she really wanted to understand more about this disease that killed her brother. And once she learned more and more, she realized how, not preventable, but how she could have done something to make him live, and maybe not be infected with this illness, but to have this treatment that could have saved his life. And so she wants to be that light for other youth, particularly, to know more about what HIV is, how it is spread, and how you can treat it, and how, you know, hopefully your life expectancy would be longer rather than being HIV positive without any treatment. And so that was really cool. I think that's just one individual who really illustrates the organizations of Treatment Action Campaign, what people are really, really trying to do to counteract this disease and to make a change in their community. But again, it's really hard to change a culture. Yeah.
How did you get connected with Treatment Action Campaign?
So IE3 is an organization that's an internship consortium based out of Oregon, and Kevin Hood is the director of it on campus here. And I wanted to go to Africa. I've always been interested in Africa, and I've always been interested in HIV, and South Africa is really the center location for that. And Treatment Action Campaign is one of the most well-known organizations in the world, so I thought that was a really, really great way for me to get experience working in this field. And so I essentially went through IE3 to get connected with them, and I was able to live in I was living in a suburb of Cape Town, and then I would drive out to the township each day to go to work. Any other questions? Yeah.
Is the maternal child transmission rate down so much because they're doing prenatal testing on these women?
So one of the reasons why the rates are so down is because they've passed a policy that says that if you are pregnant, regardless of your viral load count, you need to get on ART treatment. So there's only a certain amount of viral load. I won't, you know, bore you guys with this, certain numbers on it. But if you have a high enough viral load, you have to get on ART treatment. And so if a woman who's pregnant, regardless of their viral load count, if she is HIV positive, she would immediately get on ART treatment. Yes.
So are they having more education on like breast milk and how that's transmitting to infants too?
Yes, yes. And so we see a lot more resources and opportunity to give formula to mothers as well. Any more questions?
Well, I'd just like to make a comment. I think that, you know, it's really impressive to me how much Rachel knows and learned through this experience. You know, here's an undergraduate student who can come and keep us all mesmerized for almost an hour about her experiences, her insights, and her knowledge. And I think, you know, we really ought to give some credit here to IE3, which is a great opportunity that we have at the University of Montana. And I know there's a lot of students here tonight. If you haven't looked into IE3 yet, check in with Kevin Hood and find out some more about the opportunities. They're worldwide. They're not all in the health area, but there's lots of really interesting things you can do through IE3 that would be great investments in your future. I think Rachel is a great model for what can come out of an IE3 experience. So I just wanted to make that comment, and then let's thank her once again.